Hi, everybody. Happy Tuesday. I almost said Monday. It's Tuesday. Happy Tuesday. We will just wait a second as people make their way in to get started. But all right, I think we should get started because there are a lot of people here and a lot are still making their way. But welcome to tonight's Wu University webinar. I'm your host, Dr. Jennifer Stewart. So it's my great pleasure tonight to introduce Dr. Muckley. She's the current CEO and Executive Director at the Ohio Optometric Association. She previously was the Director of Optometric Services at Northeast Ohio Eye Surgeons in Kent, Ohio for 23 years, where she concentrated in medical glaucoma and postoperative care of the anterior segment. A nationally recognized leader in the profession of optometry, she was president of the Ohio Optometric Association in 2020 and subsequently served on the OOA Board of Directors for 9 years. She also served as past legislative chair, where she was instrumental in the passage of 3 Ohio laws, including scope of practice expansion. She's the author of the new glaucoma chapter in Lou Catania's 3rd edition of Primary Care of the Anterior Segment textbook, which was just published in 2023. She's a fellow in the American Academy of Optometry, a member of the American Optometric Glaucoma Society, and the chair of the AOA Research and Information Committee. She's a clinical associate professor of practice for the Ohio State College of Optometry. Dr. Muckley has received many career awards for her service to the profession and patient care, but most notably was recognized in 2008 as the American Optometric Association's Young Optometrist of the Year, and in 2021 as the Ohio Optometrist of the Year. She was also named by Newsweek as one of the top 100 ODs in the country. Welcome to Woo You again, Dr. Muckley. We're happy to have you. With that, I'm going to turn it over to you. I will be in the background moderating those questions, and we'll see you at the end.
Thank you, Dr. Stewart, and thank you, Wu University, for having me back. I love lecturing in this platform and to talk to all of you. Tonight, I always tell you that I'm a clinician by nature, a boots on the ground clinician. Everything I do is practical. So I hope to share some of my clinical pearls that I've learned over the years in managing medical glaucoma, where that was pretty much all I did all day before I retired from practice a few months ago full time to take on my role as the executive director. So I do have a financial disclosure. I'm still an investor in my former practice. And it's the only disclosure I have. So let's get started. Let's talk about glaucoma and dry eye. If you treat glaucoma, you have caused probably dry eye. So therefore, you need to learn and make sure that we know how to manage both conditions at the same time. Because if you're doing a lot of moderate glaucoma treatment and patients are on many medications, undoubtedly we've affected the ocular surface. And I always like to bring this slide to your attention because, DEWS 2 really helped, define really what dry eye disease is. And it helps kind of give us those diagnostic methodologies to treatment. So these flow charts are really important in guiding our treatment and how we're going to manage dry eye disease. So typically your glaucoma patients are usually very elderly, or at least over the age of 50, typically, where hormones change and our tears decrease. They're on probably multiple topical medications, both for glaucoma and maybe other types of diseases. They might have had filtering surgery or cataract surgery, and they've already got a compromised visual function, so they're not seeing well. And when you add dry eye disease on top of it, now things are even more blurry and hard to see. So contrast sensitivity can be really affected. And, decreased glaucoma medication compliance is an absolute result of patients who are miserable with dry eyes. They hate their drops, so they stop taking them and disease progresses. And we don't want to see any of those things happen. So we have to be able to recognize these dry eye patients as glaucoma patients together. It's always a good idea to assess, your patient's symptoms. It really helps identify, what is bothering them the most, what their needs are. It also helps make sure that you have documentation in order to get prior authorizations or get prescription medications covered. And there's a couple different types of questionnaires you can use. I particularly like the speed questionnaire. That's the one in my practice I use the most. It was pretty quick, pretty efficient, and very easy to do and scan into the charts. The most important thing we can do is not just pay attention to dry eyes, but evaluate all the factors that are causing dry eyes. And as Dew said, dry eyes is a multifactorial disease. There's many things that make somebody dry and throw somebody off the dry eye cliff. The biggest questions, I'm going to go through all of these, but these are things you need to ask your patients or have at the top of your head when you are evaluating these patients who have dry eyes. How many past surgeries have they had? The more surgeries they have had, they're going to have more higher risk of dryness, and especially any history of blepharoplasty. A lot of times those eyelids are lifted up, they don't have complete blinks, and their eyes are subsequently dry just from that surgery alone. Mitomycin C can also cause some limbal stem cell deficiency. So if they've had a trabeculectomy, you want to pay careful attention and evaluate a patient for that. What topical glaucoma medications are they taking? How many medications? Do these medications, what preservatives are in them? What's the total amount of drops hitting the surface of the eye per day? What are their oral medications? Are they taking oral medications that also contribute to dry eye disease? Antidepressants, diuretics, beta blockers, decongestants, and chemotherapeutic agents will cause dryness. And of course, antipsychotic and other medications. So always look at a patient's medical medicines that they're taking. Sometimes they don't even tell you they have medical conditions until you ask them what medicines they're taking. And it's really a window to their health. Do they have any contributing systemic disease? We have autoimmune conditions that can worsen dry eyes, such as thyroid. We have breast and prostate cancer that have effect on hormones. Sleep apnea with CPAP use. Those CPAP machines, they just blow out terrible dry air. And just about everybody also has floppy eyelid syndrome when they're on CPAP machines, because a lot of people that have CPAP machines are perhaps overweight already. So their eyelid skin's a little more stretchy. So assess the patient, look at them, look at their eyelids, look at their body, pay attention to these things. And do they have a history of corneal disease or herpetic disease too? And what was their age at the diagnosis of glaucoma too? Did they have glaucoma at 50 and have they been on drops for 20 years? As we age, we have decreased quality of tears and quantity with aging. And then as we start going through menopause as women, our hormones are disrupted. We also have environmental factors that contribute to dry eyes. So our environment is really critical in maintaining good tear homeostasis. Are we in a dry eye climate like Colorado or Arizona where there's not a lot of humidity? Do we live in Ohio like me where we have a winter season that lasts forever and everybody's eyes are dry and they're fine in the summer and they don't have any complaints? And then all of a sudden, the month of November, the influx of dry eye patients keep coming until we reach peak misery in the month of February. Are we on digital devices? How long? We all are. Even elderly people, don't assume they're not. They're playing their Quordle and their New York Times, Wordles and all those things. So ask about digital device use. And the big one that we often overlook are overhead fans. A lot of women who have hot flashes turn those fans on overnight. People like noise at night, white noise, and they have their fans blowing. And even if their eyes are closed, their eyes are getting dry with that fan and that night air. And then excessive heating in the house of elderly patients that have very poor circulation. Many of these patients like to crank their heat up to 80 degrees because they're always cold, or if they're on blood thinners. So that's something to consider too. Do these patients have meibomianitis or meibomian gland dysfunction? And do we need to look at that and treat that underlying condition? So don't forget that in your glaucoma patients. And lid mechanics are very important. If we have lower lid chalasis, and that means that, even though CPAP users, if they have all this excess skin pulls their eyelids down, that tear meniscus is not resting at the area of the limbus. So the tears are pulling inferior and they're not resting up on the cornea, moisturizing the cornea like they should. So pay attention and look for the pooling. If you see sclera under their limbus and their lids are exposing that, that's dryness too. And do they have conjunctival chalasis? Poor spreading of tears. We have redundant conjunctival tissue that can even fold over the puncta and cause pooling of tears. So, look for that and make sure we don't have a blocked tear duct or, epiphora from stenosis as well. And then evaluate for that incomplete blink. And certain diseases also will cause incomplete blink. We want to pay attention to that. Are they in contact lenses on top of everything? That's really important. So, we got to ask these questions. And, a quick reminder for the tools, we have tests for dry eyes, right? You can be as simple as a tear breakup time, or you can get super fancy like inflammatory or meibography. So, testing, you do have to perform Schirmer's or some tear breakup or assess how many quadrants have punctate staining. And then, document that because that's part of our prior authorization too. So we don't have to have all the fancy equipment to diagnose dry eye disease, but it's nice if you do have those. And then we have dry eye treatment algorithms from DEWS to CEDARS or Ascaris. The DEWS to dry eye treatment algorithm is pretty simple. We have step 1, step 2, step 3, and step 4. It's pretty simple to kind of give you those categories of mild to maybe mild moderate, and then moderate severe. So these are great tools to help you kind of get a treatment pattern set for yourself. And then Ascaris came up with a preoperative algorithm for a lot of patients that were undergoing elective procedures. You want patients that are undergoing those premium services to have good outcomes, and their dry eye disease oftentimes will prevent accurate measurements and good outcomes. So Ascaris developed their own flow chart for dry eye management that we can adopt as well. One thing that I cannot understate is the importance of educating glaucoma patients in dry eye disease. Dry eye patients in general are perceived as high maintenance. And then when you have a glaucoma patient that has dry eyes on top of it, they're extra high maintenance. As I mentioned before, they've got fluctuating vision, and they already have a compromised visual field and may have vision loss and loss of contrast sensitivity already. They are light sensitive when we have dry eyes, and they need more light if they have these vision losses. So that's frustrating. And they're very frustrated with the decrease in their quality of life. It absolutely affects compliance and adherence in maintaining the glaucoma therapy and decreasing the risk of progression over time. So I think it's really important to stress these topics to patients. And I would state this to every dry eye patient that I started to treat to set the expectations. 1, dry eye does not go away, especially if we're treating glaucoma and some of the treatments have caused some side effects of dry eyes. And dryness can kind of flare up and regress depending on our factors. And the environmental factors, as I mentioned, might change. Some seasons it's better, and then every November we've got the same problem again in the winter. And if the dryness is severe and there's a significant amount of surface irregularity or punctate keratitis, then it can take months to improve. So I don't want patients to think that it's going to get better in 2 weeks when it could take 2 to 3 months to resolve. And they've got to follow the regimen that we are prescribing. High maintenance disease, unfortunately, is a high maintenance regimen sometimes for these patients. And they have to understand that, they've got to continue the treatment. And if they stop, the symptoms are going to come back. And then we talk about going on a long-term maintenance plan and trying to do the least amount of products or stuff to reduce our risk of developing chronic dryness where it flares back up. So I do try to get patients on the least amount of therapy to keep them comfortable. And sometimes in Ohio, at least, summer therapy is different than winter therapy. So guess what? Lots of chair time educating these patients, and it can completely bog your day down because many of them are elderly to begin with. However, now you can document your time and bill for it. So in 2021, the coding laws changed, and time spent with patients now have a better reimbursement. You just need to document how much time you spent with the patient, all the conversation you had, and that will help support why you build a 99214 code instead of a 99213. So all those things are important. So keep that in mind. So let's switch gears and talk a little bit about preservatives. Preservatives really are a problem in glaucoma patients for dryness. Many of our glaucoma medications are preserved, and we want to talk a little bit about what these preservatives do to the ocular surface. We all know that BAK is one of the worst offenders, And the mechanism of action basically is to kill cell membranes. And because it's a detergent, it does not differentiate between bacterial cell membranes and human cell membranes. So it just kills both. And, when we have a 0.01% of BAK concentration, we get apoptosis, but you start increasing it to a 0.1 or 0.05 concentration, now we've got necrosis. So that really is important, and you need to pay attention to what medications are using BAK. And 70% of our glaucoma medications do use BAK. And why? Because it disrupts the surface so badly, it increases penetration into the aqueous. So drug companies love BAK because it helps deliver their drug into the aqueous to help decrease pressure. So it is a way that drugs are delivered. And it also allows for a lower concentration of drug because it penetrates so well if you have a higher concentration of BAK. So when Lumigan or Bimatoprost lowered their concentration from 0.03 to 0.01, they quadrupled the BAK to enhance that penetration. So BAK toxicity will definitely cause a loss of the tear film stability and damage the cornea and conjunctival epithelium. And you can see that with staining. You can even get allergic reactions to BAK along the skin and on the eyelids especially. So pay attention to that. And BAK is also present in many of the artificial tears that we all use to help treat the dryness caused by, glaucoma. Lumify has BAK in it, and so does Visine and many other artificial tears. So you might think you're helping your patient by giving them artificial tears, but really you just gave them more BAK. So keep that in mind. I took this chart from Optometry Times, and then I added Amladi at the bottom. And also, if you do happen to have the textbook that was mentioned at the beginning, Dr. Catania's new version, in my chapter, I have a chart too that has a list of all the topical glaucoma medications, preservatives, BAK concentrations, and so forth. So this is kind of helpful in looking to see, what are our worst BAK offenders and, which medicines have the highest or lowest concentrations or which ones don't have BAK in it that we can use, because many people are sensitive to BAK. So there are other preservatives that are out there to keep medications, germ-free is Polyquad, and that's found a lot in artificial tears and contact lens multi-purpose solutions and many of the glaucoma medications outside of the United States. It's a quaternary ammonium similar to BAK, but because it's a larger molecule, the epithelial cells on the surface of the eye don't internalize it. So it's a little bit more discriminatory in how it is bactericidal. Purite is another preservative that you're all familiar with. It breaks down upon contact with the air, and it does not have any ocular effect on the tissues. And so Sofzia is another preservative, and it becomes inactive when it is in contact with potassium and sodium in the tear film or in the eye. It causes death in bacteria that lack certain enzymes, and then the human cells possess these enzymes. So that's how it differentiates and is able to be basically bacteria only and not the human tissue. And Sofzia is found in Travoprost or Travatan Z. We also have potassium sorbate as a preservative that's found in Zelpros or the latanoprost emulsion. In Zelpros, the drug is delivered with Lipixel, which is a micelle emulsion formula. And you might have heard of micelle water. It's used for makeup remover, so it's got some oil in it, but it doesn't feel oily. So it helps improve the solubility of the latanoprost, which requires BAK to stay in solution. And this is why Zelpros does not need to be refrigerated. It's stable at room temperature. And it basically kind of encapsulates that latanoprost in like a castor oil, which is also, a little bit more beneficial for dry eyes. The other item to keep in mind are preservative-free glaucoma agents. These are so underrated. We have them. There's not many of them, but they do exist. We have prostaglandin option, which is Zioptin. Now, it's not probably the most efficacious prostaglandin, but it still works. And if you have patients that are allergic to all preservatives or BAK, we're kind of limited sometimes in what we can give these patients. It does lower pressure, about 7 milligrams. It's very effective. And I think it might have even gone generic this year, if I'm not mistaken. We have combination drops that are preservative-free. We have preservative-free dorzolamide timolol or COSOP PF, twice a day dosing with a 25 to 30% pressure reduction. And we're keeping patients on monotherapy to help improve compliance. And we even have a preservative-free beta blocker, which is 0.5% timolol oxidose. So remind your patients that it can take 8 to 12 weeks to reverse corneal staining and improve the tear breakup time from preservative toxicity. Again, set that expectation so patients aren't frustrated and give up on their therapy. Remember that if you have a lot of preservatives hitting the eye and you're counting those drops, preservative-free is best, followed by disappearing preservatives, followed by oxidative preservatives, and worse with the detergent preservatives. So that's kind of the order of least toxic to most toxic. Okay, so what are some clinical tools that we can keep in mind when we're treating glaucoma patients to reduce their chances of dryness and chronic problems? So the easiest thing to do is to try to keep them on drugs that you only use one time a day. And many of those are our prostaglandins or some of our combination prostaglandin medication. We want to also make sure that we don't try to prescribe 0.2% brimonidine. 0.1% alpha-GAN-P with purite does not have BAK in it, and it is much less of a risk of an allergic reaction to brimonidine than when we give the 0.2%. So I know the 0.2% is cheap, and patients have to be able to afford it, but once a patient becomes allergic to brimonidine, you can never, ever put them on an alpha-GAN-P. They'll still be allergic to it. And the likelihood of them becoming allergic on a 0.1% brimonidine is way, way less than a 0.2. When we don't have a lot of glaucoma drops in our armatorium, then we have to make sure that we don't eliminate a category of them because of allergy. So we just know that the 0.2% brimonidine is going to cause most likely an allergic reaction. It's not immediate. It can take a year or 2 years before these patients become allergic. So remember that. And alpha-GAN-P also has purite in it. I also caution you with using the Notarsadil Ropressa. It's a once-a-day medication, but it can really make their eyes look red. And sometimes it causes irritation. The redness can be asymptomatic. They can even get sometimes little subconjunctival hemorrhages, but it can sometimes cause some surface irregularity and some vortexing in the cornea. So just pay attention to that. Sometimes patients feel a lot better after you discontinue the Notarsadil if they're having some symptoms. Remember what I said earlier, there's a high concentration in 0.1% bimatoprost compared to the 0.3%. So, if they're having a lot of surface toxicity, even a simple change from a 0.1 to a 0.3 concentration might make a difference. We also want to keep in mind we have non-invasive procedures to decrease our dependency on glaucoma medications. SLT is a fantastic first-line treatment. And if I had glaucoma, I would want SLT as my very first choice for therapy, as opposed to being stuck taking an eye drop every evening for the rest of my life. And the earlier we introduce SLT to our patients, the less likelihood progression can occur too. So, compliance is improved, and we know that it's holding patients, and then it can have a retreatment if things start to wear off in 3 to 5 years. The LIGHT study came out, showed great data on intervening earlier with SLT and SLT as a first-line treatment. And with scope expansion happening, we will have this tool available to us as well to be able to deliver this to patients. We also have MIGS, micro-invasive glaucoma surgery, those procedures, iStent inject, now it's Infinite, Zen, Hydrus, Micropulse. We have EP, canaloplasty, goniotomy, goniotomy, Zen, and now the Glaukos, iStent, Infinite are approved outside of cataract surgery. So if a patient's already had cataract surgery, you kind of have a few procedures now we can choose from, even if we have to do this outside of their cataract surgery. Educate options on patients undergoing cataract surgery to have these MIGS procedures. I think sometimes it's almost an inservice and injustice to our patient if we don't educate them on these options. It might allow them to get off 1 or 2 medications, We know that cataract surgery alone will lower pressure just by creating a better outflow pathway and opening up the drainage canal of the eye. And if you can put a couple stents in, and they're so easy to go through, why wouldn't you offer this to your patients? So make sure you're sending them to doctors who do these procedures so we can intervene in their glaucoma continuum earlier and improve compliance and help the surface. We also have implantable bimatoprost or travoprost now. So, Durista and those types of products have been used to help decrease the dependency on drops and improve the ocular surface. So keep that in mind also if you're having a patient with chronic dryness that's not tolerating drops. We have Durista, who has been around for a while now. Everybody's kind of familiar with this. The pellet, it gets injected into the anterior segment. Currently, only one can be administered in the eye. We've seen it last sometimes 6 months to a year. And then trying to get approval to have a repeat procedure, that's gotten easier. So when it wears off, getting a second injection. Very few side effects and risks. We just have to kind of watch when it starts to wear off. And now we have the iDose TR, which is travoprost intracameral implant. This one has an indication up to 3 years of continuous drug delivery, and great data from their phase 3 clinical trial where patients, a good data study, they were randomized across 89 sites, and the pressure reduction from baseline over the first 3 months were almost 7 to 8 points, and 81% were medication-free still at 12 months. The only drawback is right now it's super expensive. I'm sure as time goes on, costs will come down, but if it does last for 3 years, that might be worth it to somebody to try to get that done if they're so miserable with their dry eyes. So all of these things can go through a prior authorization approval, and the companies help with that. So for moderate or advanced patients on maximum medications, we want to also maximize combination medications. We use Combigan, dorzolamide timolol, rocklatan, because that will help decrease the amount of drops hitting the eye. Sometimes insurance companies don't want to cover combination medications that are branded, and they want you to split them into the individual components, but more drops are hitting the eyes. You just have to make that extra effort and try to get that prior authorization, and tell the insurance company why you're recommending that they have this drug. You can even request a tier reduction in patients that maybe this is a tier 3 or tier 4 medication. That can happen too. So there are ways we can try to help our patients get these drugs, and our drug reps help us with that, and prior authorization websites help us too. I will tell you, be very careful with generic dorzolamide timolol. The pH is very, very acidic. The branded is not. So I have seen some really bad ocular surfaces with generic dorzolamide timolol, even though it's a combination medication. So keep that in mind. It's cheap, it's great, it works well. But if you have someone on 3 medications plus the generic, and you're starting to see a lot of surface disease, switch them out and maybe try the COSOP PF. Give them a couple examples, like a month or 2 month samples of those if you can get them, and see if that works and improves things as opposed to being on the generic. Use BAK-free or preservative glaucoma medications. We talked about COSOP PF, Zioptin, Timolol, Ocudose, Zelpros, Travatan Z, and 0.1% alpha-GAN P. We have choices that don't have BAK. I realize that they're all very expensive, but like I said, we can work with the insurance companies and make a really good case for our patients. Send your chart notes, document, take photos. All of those things will help your patient get covered. Have them file appeals. The squeaky wheel gets the grease, so to speak. The insurance companies want to hear from your patient, and they want to hear from your patient's HR company, or if they're on commercial insurance as opposed to Medicare. So they listen to them more than they listen to us. So if you have your patient call and complain and try to appeal for coverage, oftentimes that works well additionally. So we also want to be aware of any meibomian gland dysfunction in ocular rosacea or Demodex. We now have Xdemvy, which is a medication now to approve that's been approved for Demodex. Lid hygiene, let's not forget lid scrubs with hypochlor. We have Avenova, we have tea tree oil, hot compresses, all of the lid hygiene things that you're supposed to do. The masks that you microwave, very important if we have meibomian gland disease. And if we see a lot of meibomian gland disease in injection and telangiectasia, consider switching out Lumigan because it does worsen the lid hyperemia if they're on bimatoprost. So even the 0.3 O3 concentration can cause lid hyperemia. Maybe try a different prostaglandin if you can. But I do know that bimatoprost, can lower pressure, super effective. But sometimes it can't be helped to switch to a different type of prostaglandin if you see that. Treat the inflammation. We have Mibo, we have doxycycline, that works beautiful. Steroid cream to the eyelids. I try not to let patients that have glaucoma use steroids for more than 2 or 3 weeks. We don't want to get a steroid response, but sometimes you start them off with steroid cream for 2 weeks and then switch them to like erythromycin or just a plain antibiotic ointment. And then of course, LipiFlow, Tear Care, iLux is important if they've got meibomian gland disease, and we can do those treatments to the eyelids. And then Restasis, Cequa, and Xiidra can also help decrease the inflammation on the surface of the eye, even from meibomian gland dysfunction. Lubricants, as I mentioned, try to avoid the BAK ones. I love preservative-free gels like Celluvisc. It's a little thicker without completely blurring their vision. Celluvisc can be very hard to get, but it can be found and ordered. I think this is a great product and works really, really well, especially in the winter months. Really encourage those preservative-free tears, educate patients on the difference between bottle versus vial. Sometimes they have the disappearing preservative, but the vial ones really are the most hypoallergenic and safe for the ocular surface when we've got issues. Tear ointment, again, erythromycin is your better choice. Bacitracin can have a higher allergy incidence. And then we have our prescription medications for dry eyes, Restasis, Xiidra, Cequa. Remind patients that it can take up to 3 months to get that clinical effect. It might not feel like it's working those first few weeks, first month. Tell them not to give up on it until they've tried it for 3 months. So that education is really, really important. And if you forget to say that, you will have dropouts. And then you'll wonder why things, didn't work. And patients can get frustrated. Punctal occlusion, we have our 90-day extended dissolvable collagen plugs that you can use temporarily to get somebody through the winter or a situation. And then, of course, the silicone ones that are permanent, and even punctal cautery. I recommend if they've tolerated their silicone plugs really well and they've had them in for a long time, but they fall out or their punctus stretched over time, then just have them cauterize the bottom ones if it's worked well. Tyrvaya, a great product that is a nasal spray, twice-a-day dose. We like this in glaucoma because no drops are hitting the eye. It does take some getting used to. There are some side effects. Proper installation is really important. You can really have a major sneezing attack if you don't do it right. We tell patients to kind of point the tip temporally, not directly up. It's not like you're trying to clear the sinuses like with Nasonex. And that's another thing. We don't want glaucoma patients using, nasal steroid sprays that can increase their eye pressure. So make sure you caution them on that. But this is Tyrvaya. This is a dry eye drug that you put in your nose that stimulates the tear production. So education on this is important. People will kind of give up on stuff that goes up their nose unless you really tell them how to use it. So let's talk a little bit about soft steroids. I mentioned a minute ago that it's tricky in glaucoma patients to give steroids just because of the risk of pressure increase. Our soft steroids are a lot less likely to cause pressure spikes and steroid-induced, reactions. And glaucoma patients are much more likely to respond to steroids than non-glaucoma patients or even ocular hypertensives or glaucoma suspects. So these drugs work pretty well to try to help calm the ocular surface without hopefully raising the eye pressure, especially if we use them for a short course, just to kind of get a patient over the hump or, just to decrease that initial inflammation to help the other products start to take effect. So Isovis and Lotemax SM are the two soft steroids. Isovis uses a nanoparticle to help enhance the penetration and distribution. Typically 2 weeks, 4 times a day, just to calm that ocular surface down. The incidence of pressure elevation was low, but it was not studied in glaucoma patients. They were studied in non-glaucoma patients. Lotemax SM, off-label use in dry eye disease for sure. They had that submicron nanoparticle as well for 2 times the penetration compared to Lotemax gel. It has those dry eye friendly properties of the glycerin and the propylene glycol, and that pH is really close to human tears with the lowest preservative percentage. So if you got someone who's really inflamed, these are the 2 soft steroids I would recommend using to calm things down until your other therapy starts to help take effect. Modifying the environment is also important. Vaporizers, humidifiers, can't say that enough in the dry eye world. In arid climates, lack of humidity, these vaporizers are really important, especially at night when people sleep. They can even, if they have an ensuite bathroom and they don't want to clean a vaporizer or worry about mold and mildew and all that, run your shower on hot water for 15 minutes. Let that steam air into the bedroom and close the bedroom door and keep that humid as well at night. Ointments are a must at night with people who are on a CPAP machine. I tell them, just like when you put your mask on, put the ointment in your eye. So make that part of your routine, because even with a humidifier on a CPAP machine, that air blows out and definitely hits the eyes, and that mask will even pull the lids down just a little bit too. And then that can create that floppy eyelid syndrome as well. If they're on oral medications that can contribute to dryness, talk to their primary care physician, ask to be switched to something else. If they're in contact lenses, obviously daily disposables are our first choice. And then if their eyelids are just floppy or too much dermatochalasis or there's conchalasis, have surgery, get that out of the way, get their eyelids mechanically functioning better again. But make sure you refer to a surgeon who is not aggressive, who won't take too much tissue away and cause that incomplete blink. And then we have nutraceuticals that help. And, there's some, controversy about whether they really help or don't help with dry eye therapy, but I don't think it certainly hurts to try to boost the tear film with some oil. As we start getting into more advanced practices, we have autologous tears, and autologous tears are a little expensive, but Vital Tears is a company that makes the autologous tears. Tacrolimus will treat inflammation. We have now Regenerize Light or Professional, which is the placenta-based biologic drop that contains the anti-inflammatory cytokines that help with the healing properties and the growth factors for regenerative potential. 1 to 4 drops, 1 to 4 times a day. They're not preserved, and you store them at room temperature. Even more advanced in dry eye therapy is gabapentin off-label solution, testosterone oil. There are some companies that will compound these for you, vitamin A ointment. And then we're talking then using soft contact lenses to help the surface, which is not ideal in glaucoma patients. And in contact lens wearers, we don't want to, put a bandage lens on contact lens wearers. They need prophylactic antibiotics typically for this, amniotic membranes, scleral lenses. Then we're talking tarsorrhaphy and all sorts of advanced therapy if we have neurotrophic defects and oxervate. So prior authorizations definitely needed for branded and preservative-free medications and prescription dry eye medications. You have to have that documentation and supporting data. We have a 40% therapy abandon rate if a prior authorization is needed. That's the stats. So we've got to try to improve this prior authorization process. PAR-RX can really help. It helps you submit the prior authorization and saves your staff some time. We know that staff spend a tremendous amount of hours every week doing these prior authorizations, and contracting with a specialty pharmacy works well too. You contract with a specialty pharmacy, they run the prior auths, they apply the coupons, they set everything up with the insurance, and that takes it out of your hands. And it's a time saver. All right, we're going to do some quick cases before we get to the end of our talk, where I can answer all the questions you've put in the Q&A. So hang on, I will answer those. Our first case is that I've tried everything, and we all have had this patient multiple times. This is a 79-year-old female, moderate glaucoma, reports, dryness symptoms. She's coming for a second opinion after dabbling in dry eye therapy with no success. She was under the care of another practitioner for 8 years. She tried tiered gels. She tried topical cyclosporin for 4 weeks, but it didn't work. It burned and made it worse. Had plugs, but they fell out. Nothing works. Now, I want you to pay attention to what I'm highlighting in red as we go through this case, because these are things that sometimes we don't pay attention to, we gloss over, but there are some important things in a case history that will help us, maybe do things better for this patient. Patients are complaining, she complains of foreign body sensation, burning, watering, photophobia, fluctuating VA, and when she reads or crochets. And when I hear crochet and sew, those patients are staring all day. Detailed, oriented, visual task, always dry. And they're usually women with no hormones. So her ocular history, she was diagnosed at age 61. Her family history of glaucoma is positive. She's relevant also for cataract surgery 5 years ago and SLT. Her topical medications are generic dorzolamide timolol twice a day in both eyes and 0.1% Lumigan at night. Oral meds are hydrochlorothiazide, Lipitor, Lexapro. Visual acuity is good. Pressures are 15, 14, pretty much under good control. PACs were reasonable. Her Tmax in the past prior to treatment were in the upper 20s. Her pressure goal was unknown because she was seen by a previous provider, but reports that her provider was pretty much happy with that goal. So I highlighted these things in red because these are red flags for me as to contributing to the dryness and what can we do to possibly modify some things. So taking a look at her lids, they showed no capped oil glands, minimal collarettes, minimal flaking. She did have some periorbital darkening that was associated with the prostaglandin use. And she did have some lower lid dermatochalasis. And you can see in this picture how we can see limbus and sclera exposed between the lids. So we've got the limbus, the sclera, and the lid. Her lid should be higher. We should be covering a little bit of the limbus there. So her tears are resting really low, which explains why we have this kind of, interpalpebral kind of blink. She's probably not always completely closing her eyelids when she blinks. And because her lids are resting so low, we've got a lot of punctate right there. She had about a 1/4 millimeter tear prism and her tear breakup time was pretty low. Cornea, showed that moderate punctate. I would call that in 2 quadrants or like 30% staining if the insurance company wants to have you document it that way. Here were her OCTs, moderate glaucoma, you can see there, and corresponding visual fields. So I educated her on her dryness being multifactorial. Some of the modifiable things that she was doing with her current therapy, we changed. Took her off that generic dorzolamide timolol with that high pH, the acidic pH, I should say low pH, but more acidic. Generic travoprost I recommended as well because of the decreased BAK. So getting her on the COSOP-PF and latanoprost or generic travoprost are the better ways of treating her. She could use Zelprost, but that could be a little more expensive. So that's one change. I recommended a nighttime tear ointment because of that lower cornea staining and exposure. Recommended some Celluvisc or preservative-free tears 4 times a day. Talked about a vaporizer. And, simple changes worked. And she was really happy when she came back. She felt 80% improvement. But if that hadn't worked, then our next approach would have been plugs. We can re-challenge the cyclosporin since she was only on it for 4 weeks. We can talk about Tyrvaya. And again, not a fan of steroids unless nothing else was working. And then we can still talk about Durista or the new travoprost implant, MP3 laser. She's already had SLT. We could go and even do a iStent Infinite MIGS that's approved outside of post-cataract surgery. So this next case, and I'm kind of watching our time, is a 72-year-old female glaucoma patient presenting with the itching and crusting of the lids. She complained of burning and crusting in the morning, foreign body sensation, especially when instilling her glaucoma drops. She feels her vision fluctuates and is concerned she's having a reaction. And her medical history is remarkable for, hypertension, diabetes, and on treatment for that. She was diagnosed in 2009 by me. Her Tmax was 32 and 34. Gonioscopy was open to ciliary body, PACs were low, and her baseline CDs were 0.5, 0.6. Back then, we started her on Travatan Z in 2009 with a pressure goal of 18. And over time, she did pretty well, but she did develop some progression despite her pressure being at goal. So we instituted SLT in 2015. Her goal was now 14 in 2019. And, at that time, she was on the 0.1% bimatoprost and 1% brinzolamide twice a day. She did have a history of allergy to brimonidine with a past trial, so that eliminated that class of medication. And her current pressure was at or under goal on that treatment. So there's some pictures of her nerves. These are the old OCTs from long ago in the beginning. So you can see, some thin there now with our new technology, and then some visual field changes, but not bad. So this was her. You can see a couple of things here. We can see the capped glands. You can see the telangiectatic vessels, the inflamed vessels. You can see the areas of negative staining. And if you look at her skin, I know this isn't a great picture, but you can see we've got telangiectatic vessels on her cheeks, and her chin too had it. So when we see this, we know we're dealing with ocular rosacea and subcutaneous rosacea complexion and just oil producing. And these people may have had even oily skin as a teenager. You can see the froth, the capping, all of that. And, we look to see if we've got crusting and lids and, possible Demodex, and meibography is showing damaged glands. So what we actually did, and what I actually did, was I kept her on her current meds because they really weren't that bad. What was really probably causing most of her problems was the meibomianitis and the ocular rosacea. So lid hygiene was instituted. We did recommend tear care. That's the product I have in my office, but it was too costly for her. So we did do a Maxitrol ointment to her eyelids for 2 weeks and then changed her just to erythromycin long-term. I did start topical cyclosporin because it does reduce inflammation, and doxycycline 50 milligrams daily. Nowadays, because we have these new products invented, we have Xdemvy and Mibo. I probably would have put her on the Xdemvy at that time, but doxycycline also really helps work long term and helps the skin too, which I'm going to show you here in just a minute. If you're going to put someone on doxycycline, I don't recommend anything more than 50 milligrams a day. The 100 milligrams oftentimes will just cause an upset stomach. And studies have shown that 50 milligrams is just as effective with less side effects. And it's pretty inexpensive when you do it that way compared to like the Oracea, which is 40 milligrams with 10 milligrams sustained release. The 50 milligrams generic is not that as expensive. I tell patients that we're going to keep you on it for 90 days. It's going to take 90 days to get a clinical effect maximum. You'll start to feel maybe a little better, maybe 20% better at 2 to 3 weeks on Doxy. By 6 weeks, more better. And then by 3 months, we'll have a good clinical effect. And then also don't forget Metrogel cream to the face and to the periorbital area as well. Helps with that condition and the rosacea. So again, this was her before picture. You can see all the telangiectatic vessels, the pustules, and look at her after picture in 3 months. What a huge improvement in her skin, and her eyelids looked great too. So that's just the power of doxycycline. Steroids are also helpful. So this is a time when utilizing those soft steroids would be helpful as well. So treating the inflammation is really important. This will be our last case. We'll whip through this and then we'll answer some questions. This last case is a 63-year-old female who had moderate glaucoma in her right eye and advanced glaucoma in her left. She complained of chronic dryness and irritation in that left eye only, constant burning and light sensitivity. In the right eye, she had medications, latanoprost and Comigan. The left eye had none because she had had a trabeculectomy with mitomycin C in 2019, and her pressure was low enough that she could be off the medications. Unfortunately, her acuity had been affected from the glaucoma, which is why she had to have a trabeculectomy, but her pressures were under good control postoperatively. So she had a very decreased tear meniscus in both eyes. In her left eye, she had a really 3+ thin elevated bleb, no leak, and no vascularization. She did have trace punctate in the right eye, but in her left eye, she had this whorl type punctate appearance. And I'll show that to you on the next slide. It was kind of swirly and translucent and had kind of some triangular, there you go, appearance. So that's not just like tears or staining. That's more of a whorl appearance. And then the staining had this kind of whorl triangular appearance. So this can be very diagnostic of limbal stem cell deficiency. And this can be very easily missed in contact lens wearers too. So I want you to really pay attention to limbal stem cell deficiency in contact lens patients and then patients that have had mitomycin C. It's a deficiency of those stem cells, and that's what's needed to help generate corneal epithelium. Mitomycin can cause limbal stem cell deficiency. It's a medication that reduces scarring and it inhibits the fibroblast proliferation, which can damage the cells. So we know she's got permanent damage. We talked about it, told her what was going on and why she had it. And we needed to improve that tear film and healthy epithelium. So this is a case where more severe therapy would be introduced: autologous serum, amniotic membranes, those types of therapies. So when we kind of got her on those autologous tears and chronic tear ointment at night and Celluvis during the day, her symptoms improved, but she had to do this maintenance ongoing forever. So I just want to bring stem cell deficiency to your attention. It's important not to miss that. So remember, in conclusion, ocular surface disease is multifactorial. We have to have extensive patient education and a stepwise treatment to manage this and develop success in treatment. We have algorithms that will help us have patience for these patients. And, it's a really opportunity for you to develop a relationship with these patients and make a difference in their lives. Reduce the amount of drops hitting the surface daily, reduce that BAK, and intervene with SLT and MIGS procedures to reduce our dependency on drops.